Welcome to our lecture on knee pathologies. The knee is one of the most commonly injured joints you'll encounter in clinical practice, and understanding how to differentiate between ligamentous, meniscal, and patellofemoral conditions is essential for accurate diagnosis and treatment planning. Let's get started. Let's start with the anterior cruciate ligament, or ACL. This is one of the most common and significant knee injuries you'll see, particularly in athletes. The majority of ACL injuries are actually non-contact. The typical mechanism involves a planted foot with the tibia externally rotating while the knee is forced into hyperextension. Patients often describe hearing a loud pop and feeling like their knee just gave out or buckled beneath them. On examination, you'll typically find immediate swelling and hemarthrosis, meaning blood in the joint. Patients report a feeling of instability and pain that worsens with weight bearing. Now, when a contact injury does occur, it's usually a valgus force, meaning a blow to the lateral side of the knee. This may also cause an unhappy triad injury. Quick tip: the unhappy triad, also called the terrible triad, involves combined injury to the ACL, MCL, and medial meniscus. This happens when valgus, flexion, and external rotation forces are applied to the knee while the foot is planted. If you suspect an ACL tear from a contact mechanism, always assess the MCL and medial meniscus as well. When examining the ACL, remember this helpful mnemonic: LAPS. L is for Lachman's, A for anterior drawer, P for pivot shift, and S for Slocum. The first test is Lachman's test, and this is considered the gold standard for ACL tears. Lachman's is performed with the patient supine and the knee in slight flexion. You stabilize the femur with one hand and pull the tibia anteriorly with some external rotation with the other. A positive test shows the tibia translating forward with a mushy or soft end feel rather than the normal firm stop. The second test is the anterior drawer test. This one's performed with the knee at 90 degrees of flexion. You sit on the patient's foot to stabilize it, then pull the tibia forward. A positive finding is excessive anterior glide compared to the other side, again with that mushy end feel. The third test is the pivot shift test. This assesses rotary instability. You apply a valgus stress and internal rotation while moving the knee from extension into flexion. A positive test produces a clunk as the tibia relocates during the movement. The fourth test is the Slocum test, which is essentially a modified anterior drawer. You internally rotate the tibia 30 degrees by rotating the foot. The examiner then pulls anteriorly on the tibia. Excessive anterior translation with tibial rotation indicates a positive finding. Moving to the posterior cruciate ligament, or PCL. This ligament prevents the tibia from sliding backward on the femur. The classic mechanism is called the dashboard injury. Picture a car accident where the knee is flexed and the anterior tibia strikes the dashboard, driving the tibia posteriorly. PCL injuries also occur from falling directly onto a flexed knee. Patients report pain in the posterior aspect of the knee that gets worse with kneeling. They may have heard a popping sound at the time of injury. Keep in mind that PCL injuries are often accompanied by damage to other structures, so a thorough examination is important. For testing, the posterior drawer test is considered the best test for PCL tears. Position the patient supine with the knee at 90 degrees, similar to the anterior drawer setup, but this time you push the tibia posteriorly. A positive finding is excessive posterior translation compared to the other side. The posterior sag test, also called Godfrey's test, is a simple observation test. With both hips and knees flexed to 90 degrees, you observe from the side. If the tibia sags backward relative to the femur, that indicates PCL insufficiency. The reverse Lachman's test is performed similarly to the standard Lachman's, but with a posteriorly directed force. Increased posterior translation on the suspected side is a positive finding. Now let's compare the collateral ligaments. The medial collateral ligament, or MCL, and the lateral collateral ligament, or LCL, provide side-to-side stability. The MCL is injured by a valgus force, which is a blow to the lateral side of the knee that pushes the knee inward. You test it with the valgus stress test by applying an outward force to the knee. The LCL is injured by a varus force, which is a blow to the medial side that pushes the knee outward. You test it with the varus stress test by applying an inward force. Here's an important clinical pearl for testing. When you test at 30 degrees of flexion, you're isolating the collateral ligament. When you test at 0 degrees or full extension, you're also stressing the cruciate ligaments and the posterior capsule. So if you find laxity at full extension, suspect involvement of multiple structures, not just the collateral. A positive finding at 0 degrees indicates greater injury and poorer outcomes comparatively. For grading ligament sprains, remember this pattern. Grade 1 has minimal pain and minimal laxity. Grade 2 has moderate to severe pain with moderate laxity. Grade 3, the complete tear, often has little to no pain but high laxity. That's counterintuitive but important. When the ligament is completely torn, there's nothing left to generate pain signals, but there's significant instability. The menisci are the shock absorbers of the knee. There's an important anatomical difference between the two that affects injury patterns. The medial meniscus attaches to the MCL, which anchors it in place, but also makes it more prone to injury. The lateral meniscus floats more freely because it doesn't have that ligamentous attachment. Meniscal injuries typically occur from a combination of compression, rotation, and flexion. This creates shear stress on the meniscus. Think of twisting on a loaded bent knee. Patients present with joint line pain on either the medial or lateral side, depending on which meniscus is involved. They often describe mechanical symptoms like clicking, catching, or locking of the knee. You may also observe joint effusion and reports of the knee giving way. Two main tests assess meniscal integrity: McMurray's test and Aplay's compression test. McMurray's test is performed with the patient supine. You flex the knee fully, apply rotation and either valgus or varus stress, then extend the knee. For the medial meniscus, you use valgus stress with external rotation. For the lateral meniscus, you use varus stress with internal rotation. A positive finding is a click, pop, or pain along the joint line during extension. Aplay's compression test is performed with the patient prone and the knee at 90 degrees. You apply downward compression through the tibia while rotating. Pain with compression plus rotation indicates meniscal pathology, while pain with distraction indicates ligamentous injury. It helps you differentiate between the two. Patellofemoral pain syndrome, or PFPS, is also known as chondromalacia patellae, or runner's knee. It's common in runners and athletes and is more prevalent in females. The underlying issue is abnormal tracking or loading of the patella within the femoral groove. Contributing factors include repetitive overuse, an increased Q angle, weakness in the vastus medialis obliques, or VMO, and lateral patellar tracking. Patients describe a dull, aching pain in the front of the knee, specifically around or behind the patella. A classic presentation is moviegoer's sign, which is pain that develops with prolonged sitting with the knee flexed. Pain also typically worsens with descending stairs, squatting, or any activity that loads the knee in flexion. For testing PFPS, Clark's test, also called the patellar grind test, is performed by applying downward pressure to the superior pole of the patella while the patient contracts their quadriceps. Retropatellar pain or crepitus is a positive finding. McConnell's test is helpful for confirming the diagnosis and guiding treatment. Have the patient perform isometric knee extension at different angles. If they have pain, repeat the contraction at that angle while you push the patella medially. If the pain is relieved with the medial glide, that's a positive test and tells you that medial patellar mobilization and taping will likely help this patient. For rehabilitation, focus on VMO and gluteal strengthening, along with medial patellar glides and McConnell taping. Avoid deep squats and stairs during the acute phase. There are specific precautions for exercise selection. With open chain exercises, avoid the last 30 degrees of extension, and with closed chain exercises, limit the range to 60 to 90 degrees of flexion. This keeps patellofemoral joint forces manageable while still allowing strengthening. Let's cover patellar tendinitis. Patellar tendinitis, commonly called jumper's knee, is a degenerative condition of the patellar tendon. Patients have point tenderness at the inferior pole of the patella where the tendon attaches. It's aggravated by explosive movements like jumping, acceleration, and deceleration. Typically, you'll find that patients have decreased ankle dorsiflexion and quadriceps inflexibility. Treatment emphasizes isometric loading protocols, which have strong evidence for tendon healing. Perform exercises like wall squats. IT band friction syndrome is common in runners and cyclists and results from repetitive friction of the IT band over the lateral femoral epicondyle. Here's an important anatomy point. The IT band is fascia, not muscle. It cannot be directly stretched. Treatment must focus on stretching and releasing the muscles that attach to it, specifically the tensor fascia latae and the gluteals. Patients report sharp lateral knee pain that's often hard to localize. They'll notice it with repetitive movements like running or cycling, and particularly with climbing or descending stairs. 2 tests to know: Ober's test and Nobel's compression test. Ober's test assesses IT band and TFL tightness. Position the patient side lying, abduct and extend the top leg, then slowly lower it toward the table. If the leg remains abducted and can't drop to the table, the TFL is tight. The Nobel compression test assesses for friction syndrome. Apply pressure over the lateral femoral epicondyle while extending the knee from 90 degrees of flexion. Pain at around 30 degrees of flexion is a positive finding, because that's the angle where the IT band crosses the epicondyle. Let's briefly cover 2 less common conditions: osteochondritis dissecans and Plica syndrome. Osteochondritis dissecans, or OCD, involves subchondral bone that becomes necrotic and can separate from the surrounding bone. This primarily affects children and adolescents, most commonly between the ages of 10 and 20, as their bones are still developing and growing. Wilson's test helps identify this condition. Have the patient extend their knee from 90 degrees while keeping the tibia internally rotated. Pain at around 30 degrees that disappears when you externally rotate the foot is a positive finding. Plica syndrome involves inflammation of synovial folds within the knee. Houston's Plica test is performed by moving the knee through flexion and extension while applying medial rotation through the tibia and a medial glide to the patella. A positive finding is palpable popping of the Plica band. This wraps up our lecture on knee pathologies. For more videos like this, visit typicalpt.com. The full course covers every topic on the NPTE to help you pass the first time. Thanks for watching, and we'll see you in the next one.